actually a good this is actually a good way to end our discussion of myopathies, because like I told Robbie this morning, this is the most challenging diagnosis to make in muscle disease, because these myopathies are frequently very subtle in terms of their clinical presentation. A lot of people actually think they're hysterical when they see them because they're complaining of these fluctuating or intermittent symptoms. You know, the exercise intolerance, the muscle pain, the cramps, and frequently they have normal physical exams and even very normal workup. You know, can have normal CKs, normal EMG, normal MRIs, etc. Unlike the previous few days where muscular dystrophies, myositis, you know, can obviously present with fixed weakness and can have very abnormal workups. So that's why I've actually missed a few cases of metabolic myopathies. So when you think of the metabolic myopathies, there's three main categories. Is it the glycogen storage disorders? Is it the mitochondria? Or is it the disorders of fatty acid oxidation? And all three of these are essential to production of energy, right? To creating ATP for your different body processes, for your muscles to contract. And like I said, you know, all of these will have exercise intolerance. Most will have episodic weakness. So again, not fixed weakness. The glycogen storage disorders will have more cramps. The fatty acid oxidation disorders, more myalgias. Very rarely do we see myoglobinuria, but if somebody's having recurrent myoglobinuria and you've ruled out muscular dystrophies, you should think of the metabolic myopathy. And like I said, you can get episodic elevated CPK, usually in the setting of exercise. So what do you get in the history? So the history can be very subtle, right? People will say, well, you know, I was never athletic. I always had trouble keeping up with my friends. Now, again, not every unathletic person in the United States of America has a metabolic myopathy. But if somebody's like, I was the best athlete, I was fastest in my class, they probably don't have a metabolic myopathy. And when we talk about the glycogen storage disorders, you know, because these are the most common metabolic myopathies, you know, they're still pretty rare. It's about 1 in 20 to 30,000. There are 14 of them, and nobody's expecting you to know all 14, but to know Pompei's disease is reasonable. To know McArdle's disease is reasonable. And again, these disorders affect both muscle and liver. So I bring up things like the Krebs cycle because this is involved in production of energy, right? In the aerobic pathway, it takes over from the anaerobic pathway. So again, we're just looking at it, having flashbacks to med school, and we'll go on from there. And we have to know a little bit about muscle metabolism. So the question is what energy source do muscles use based on how active they are? So when you're at rest, you actually don't use glycogen, you use the fatty acids. When you're doing very intense exercise, when you begin, you start with anaerobic glycolysis, right, over here, right? And then as time goes on, you will then use things like fatty acids and those. If it's low intensity sub-maximal exercise, you know, you'll start using glucose, then the free fatty acids. If it's going to be high intensity, then it's aerobic metabolism. So in the beginning, you're sort of burning through with the anaerobic pathway. But once you really persist and you keep going, then you're using the aerobic pathway for glycogen utilization. Now, if it's more mild exercise, especially long-term, it's frequently the fatty acids. So if it's going to be intense exercise, it's glycogen. If it's going to be submaximal exercise, it's glycogen, first anaerobic, then aerobic. And if it's going to be mild exercise, whether it's brief or for long periods, then it's actually fatty acid oxidation. And again, it's important because if the patient said, well, you know, I worked out a little bit and I had terrible, you know, problems, that's probably a fatty acid oxidation disorder. If somebody's like, yeah, I was working out intensely and I was wrecked, then that's a problem with, you know, glycolysis, anaerobic glycolysis. So it sort of tells you what metabolism is most effective. So with the glycogen storage disorders, it's Pompei's disease is the one that we know about most. And we know that the less enzyme you have, the more clinically you're affected. So based on the type of mutation in the GAA gene, you can have no no activity of the enzyme, and then you will have an infantile presentation of Pompei's disease. You can have a little bit of enzyme, so you'll present in the pediatric years, or you can make, a third of normal and you'll present in the adult years. And we call that late onset Pompei's disease. And for the adult people in the room, you're going to see late onset Pompei's disease theoretically. For the pediatric people, you will see it at birth, and these are the floppy babies, or you'll even see it in the pediatric years. So what is the infantile onset? That's usually within the first 6 months of life, sometimes even at birth. So these are patients who are floppy babies. They have cardiomegaly and heart failure in 90%, which can kill you. They also have respiratory distress, hepatomegaly, and diffuse weakness. Again, 90% or so. Without treatment, 4/5, everybody more would basically die within a year. When I was a resident and a med student, we didn't have enzyme replacement, so kids just died. Now we have Lumazyme, which is an enzyme replacement therapy, and that improves the cardiomyopathy. It improves the diaphragm, so you're able to breathe better. The heart is better. They don't work as well on the skeletal muscles, but they do get stronger, and they live longer, and they can live up to a decade of life at least. And there are other therapies that are on the horizon. Nexviazyme is approved, but not for pediatric, and AT-GAA is not yet approved. And this is for the adult people in the room. So this is where you might see them, and it could be anywhere from the 3rd to the 6th decade of life. We did have a 75-year-old that we thought had Pompei's disease, but we weren't able to prove it. That would have been a case report. But anyway, it's in adulthood, and it's characterized by insidious onset of proximal weakness of the legs and the arms. So they can have exercise intolerance. Some will have some hepatic dysfunction. They can develop head drop. They do get what we call disproportionate ventilatory weakness. So these are patients who, when they're asleep at night, right, their airway collapses, they have sleep apnea. You'll notice on their respiratory testing, the pulmonary function testing, they have problems, right, with ventilation because of the restrictive pattern, because they have diaphragmatic weakness. And this is out of proportion to their skeletal muscle weakness, to their extremity weakness. So if you have somebody who's failing pulmonary function tests and has mild proximal weakness, you want to think of Pompei's. And you diagnose it obviously on genetic testing these days. We used to use biopsies, right? I'll show you a picture. On the biopsy, you could stain for the glycogen and see these pools of glycogen, but now we just do genetic testing. And it actually is on newborn screening. So in New York State, for 10 years, we've actually had newborn screening for this. What's important, the reason we bring up EMG is we almost never diagnose them on EMG these days. But not only, it looks like an irritative myopathy. So remember I said yesterday with the myositis, you get spontaneous activity? You can see spontaneous activity on Pompei's, even though it's not an inflammatory disorder. And more confusingly, you can actually see myotonic discharges. So, for somebody like Robbie next year is going to be doing EMGs, if you see myotonic discharges, especially in the thoracic paraspinal muscles, in a patient with proximal weakness, you want to think about Pompei's disease. And at that point, you would then obviously do genetic testing. And this can be treated. You can treat this with enzyme replacement. And what it does is they improve, then they stabilize, and then they start to worsen. But that can be after 5, 7, 10 years, and they could present exactly like a limb-girdle muscular dystrophy. So I diagnosed a guy, I thought he had limb-girdle, and I sent the genetic testing, and luckily in that panel, they also tested for GAA, and he came back positive for GAA. And he has a twin brother who also trouble getting out of a chair, climbing the stairs, looks like a limb-girdle. So this is the biopsy, and you can see over here, these sort of pools of glycogen, these collections of glycogen over here, and you could stain for that. Now, another glycogen storage disorder is what's called de Brancher's disease. So this is another type. It's the 3rd most prevalent GSD. It's more common in males. You'll see this in kids in neurology because they have seizures and hypoglycemia and cardiomegaly. In kids, they'll have hepatomegaly and liver issues, and then weakness, which usually gets better. In adults, they actually present like Pompei's with proximal weakness, ventilatory weakness, exercise intolerance. And again, you can do genetic testing for it. You could do the biopsy, and the same biopsy will also show you these pools, these with vacuoles of glycogen that are we call PAS positive. So it'll look very similar to this. And then the last one is McArdle. So McArdle's, everybody knows, like we discussed, this is the second wind phenomenon, right? It's the second most common GSD. The mutation, unfortunately, doesn't predict how severely affected you will be. It usually presents in late childhood, but can occur in young adults. And usually there's fixed proximal more than distal weakness, but they can have very severe exercise intolerance and fatigue. So they can do moderate exercise, but they cannot do intense exercise. And this is the second wind phenomenon. So they briefly, they start exercise, they get muscle cramps, they get muscle pain, they rest briefly, then they can exercise without the pain, and they can exercise more, okay? They do have myoglobinuria sometimes, and they actually can look like hypertrophic muscles in the deltoid and the calf sometimes. And they can have elevated CKs. So unlike Pompe's and other glycogen storage disorders, which sometimes have normal CKs, McArdle's is usually elevated. And we do what's called the non-ischemic forearm test. So we have them activate the forearm. So they're using up the glycogen, and you will see reduced lactate production, which normally you should see a lot of lactate when you activate the muscle. The way that you treat this is you actually give them sucrose before exercise. So they don't have to rely on breaking down glycogen. They can just break down the sucrose, which is very easily metabolized, okay? Other people will actually give them B6, creatine, but how useful it is, nobody really knows. So those are glycogen storage disorders. So you have, Pompe's, right? Infantile and late onset. You have debranchers, where there's a lot of seizures, liver issues, adult onset, where they do have weakness and exercise intolerance. And then you have McArdle's disease, where you have the second wind phenomenon. It's, the second most common GSD, usually in late childhood, early adulthood, with the second wind phenomenon. So another type of metabolic myopathy is the mitochondrial diseases. So remember, the mitochondria produce the energy in the cell, right? We think that we have a symbiotic relationship with the mitochondria from millions of years already. So mitochondrial diseases are tricky because of the pattern of mitochondrial genetics. So we know that most mitochondrial proteins are actually nuclear encoded. They're actually not mitochondrial included. So when you're looking for mutations that cause mitochondrial syndromes, frequently it's not a gene in the mitochondria, it's actually a gene in the nucleus that controls the mitochondria. And in mitochondria, remember, there's something called the threshold effect. You need a certain percent of mutant mitochondrial DNA above a threshold to produce clinical manifestations. So if you don't hit that threshold, you're not clinically symptomatic. The other thing is also there's something called heteroplasmy, that you need to have a certain number of mutations passing the threshold in a tissue. So for example, you may have more mutant mitochondria in the heart than the skeletal muscle, and that patient will have a cardiomyopathy. Other people will have more of the mutations in the muscle, in the skeletal muscle, so they'll be weak, but their hearts will be fine. So the threshold for disease, differs where the number of mutations are. And the other thing is the threshold for disease, that threshold effect depends on the tissue. If you're very dependent on oxidative metabolism, like the brain and the heart, you have a lower threshold effect. You don't need as much mutant DNA and mitochondrial DNA to produce clinical abnormalities. Okay, so in the brain and the heart, low threshold effect, you don't need a lot of mutated mitochondria, you will have clinical manifestations. Okay, and again, finally, this is maternal inheritance, right? You're getting this from mom, right? This is not recessive, this is not dominant, this is mom. So that's what we care about. So if you have women in the family passing this on, it's mitochondrial to proven otherwise. And again, mitochondrial diseases can present with an array of abnormalities. Seizures, you may see this in epilepsy clinic. Ataxia, you may see this in ataxia clinic. You can see this in movement clinic. They can have dystonias. You can see HSP, hereditary spastic paraplegia. It can cause a myopathy, it can cause a neuropathy, right? It can cause hearing loss, it can cause cardiomyopathy, diabetes, and short stature. So there are classic mitochondrial diseases that we all have to know. So MELAS is a big one. And if you PubMed me, that was, I think, the second paper I ever published as a fellow in population of MELAS patients. And these basically have encephalopathy with lactic acidosis and stroke. And the reason you have to know that as a neurologist is these patients will present with what looks like a stroke, but there's no vascular impairment, right? There's no problems with perfusion. And the pattern of weakness and the changes on MRI don't fit a vascular territory. And what happens is whatever stress they're under, physical stress, infection, which stresses the mitochondria and leads to these stroke-like episodes, once you remove that stress, they get better, which obviously doesn't happen with the stroke. MELAS patients can also have seizures, half have myopathy. I published on neuropathy in these patients, and they can have mental retardation. And basically, you diagnose it not with lactic acidosis. Now you look for this mutation in this one particular gene, which you don't have to know. And the treatment is people have actually tried taurine or arginine, these amino acids during these stroke-like episodes. You know, how well they work, I don't know. You can't see me shrugging, but who knows? Another very common mitochondrial disease, which is they love asking on the boards, is Kern-Sayer. That's known as progressive external ophthalmoplegia. So these patients can't move their eyes. They can have retinitis pigmentosa. They can have heart block. They can have myopathy, you know, as well. So how do you diagnose mitochondrial diseases? You know, don't look at the lactate and pyruvate. Please don't send it off. It has to be, you know, put on ice immediately. The lab never does it properly. You'll get false results. Don't even waste your time. So we do either muscle biopsies, and with there, what you can see is ragged red fibers on Gamori trichome staining, which is this. These are the ragged red fibers, and this is Gamori trichome staining. So if you think somebody has mitochondrial disease, this is the staining that you should do. You will see these ragged red fibers. This is a classic example. But again, more frequently these days, we do genetic testing. So based on where you think what disease it is, you could try to match it up with a particular gene. Or what we frequently will do is we'll do genomic analysis of all of the mitochondrial genes, and then we'll also include certain nuclear genes, because as I said, nuclear genes are frequently responsible for mitochondrial function. And if you have a mutation in a nuclear gene, you might also then develop mitochondrial dysfunction, such as a myopathy or something else. So it's pretty important. Now, the trouble is it's also important where you get your DNA from. You know, if somebody has a mutation, you know, more mutant, you know, mitochondria in the muscle, you would want a muscle DNA, a biopsy, and then look at the DNA. But for certain mutations, blood DNA is enough. So sometimes it depends where you're getting the tissue from, where you're conducting the genetic analysis. So that's the mitochondria. So again, can have movement disorders, they can have seizures, they can have mental retardation, they can have eye movement problems, they can have diabetes, short stature, you know, anything that requires a lot of energy, like the extraocular muscles, the brain, are frequently affected in mitochondrial disease. And then finally, finishing up with the fatty acid oxidation disorders, these are inborn errors of lipid metabolism. And there's a deficiency in the enzymes to break down the fats. And these are autosomal recessive. So basically, you need to use oxidation of long-chain fatty acids to have energy homeostasis in your hearts, in your muscles, things like that. If you're not able to oxidize the fatty acid, that will lead to energy failure and build up these fatty acetylcholinesterase that cause urinary excretion of acylcarnitine and other conjugates that cause carnitine deficiency. So how do you avoid fatty acid oxidation disorders? You want to avoid prolonged fasting, because remember, when you fast, you use your glycogen stores first, your glucose glycogen, then you start getting to the fatty acids, right? This is why when people diet, that's why they diet. They want to blow through their glycogen stores, then break down their fats. So you want to avoid doing that if you have a fatty acid oxidation disorder. You also want to avoid excessive muscle effort, right? Remember, we said that if you have certain muscle effort, especially prolonged mild muscle effort, that will use up the fatty acids. So you want to avoid that kinds of muscle activation. The other thing you can do is you can give a diet rich in complex carbohydrates and low in fats. Again, less fat, you don't have to worry about fatty acid oxidation. Complex carbohydrates, you can make sure they spend a lot of time metabolizing the carbohydrates before they need to get to the fats. And then finally, you can use things like riboflavin because that can sometimes cause expression of partly active enzyme variants in this fatty acid oxidation. So some people will give riboflavin to take along with their meals. And this is some of the pathology. If you do a biopsy, you actually see these droplets over here and over here and over here of fat, basically, in the muscle. If you do certain staining, you can see the fatty droplets in the muscle over here. Whoops, sorry, over here. So you will see that even on just regular microscopy. So one of the classic fatty acid oxidation disorders is called primary carnitine deficiency. And this is important because you can treat this with carnitine and really improve the phenotype. So these patients can present differently based on the age of onset. So frequently they'll have myalgias, fluctuating weakness, but what you have to remember, especially for the pediatric neurologists, is there's hypoglycemia with or without ketoacidosis. So if somebody comes in with weakness, but they're having persistent hypoglycemia, you want to think of this diagnosis. So in infants, they have hypoketotic hypoglycemia. They can also have increased ammonia and transaminitis and hepatomegaly. In childhood, they will present with a myopathy and cardiomyopathy. And in adulthood, they'll present with cardiac arrhythmias, but also fatigability. So again, for the pediatric people, if you see kids who are developing with encephalopathy, seizures, hypoketotic hypoglycemia, and some weakness, you think of carnitine deficiency. Or in childhood with myopathy. For us in the adult world, somebody who's having fatigability and cardiac arrhythmias, you at least think of it. Because again, you don't want to miss it. You can treat it with a certain amount of carnitine per day. The other very common disorder is what's called CPT2 deficiency, or carnityl palmitoyltransferase deficiency. And what that does, it's a deficiency of long-chain fatty acid oxidation. It's very uncommon, right? 1 in 250,000, it's recessive. And basically, CPT2 is located in the inner mitochondrial membrane. So if you lack this, you can't basically move the fatty acids in your oxidation cycle, and you can't then produce energy. So if you get it in the neonatal form, you're dead. If you get it in the infantile form, you have hepatocardiomuscular disease. So, hepatic disease, cardiac disease, muscle disease. If you get it in adulthood, it causes these recurrent episodes of muscle pain and weakness and rhabdo. So if somebody's coming in and they're going like, I'm peeing dark urine all the time and I'm having bad pain and I'm weak, and if it's triggered by prolonged exercise, like we were saying before, or fasting, or high fat meals, or even colds, you want to think about it. And these people could come in with pain and stiffness and cramps, but they'll sometimes have extremely high CPK levels, especially right after they've been exercising, triggering an attack. Now, again, you want to make sure you're not confusing this with things like McArdle's disease, right, which can also present with elevated CK and cramps and pain, and they can get worse initially, right? But again, the difference is that obviously one is glycogen storage, one is fatty acid oxidation, okay? So how do you diagnose it, right? You can show in the plasma and the urine that there's decreased carnitine and total carnitine in the plasma, or you could do genetic testing for this for the gene that's involved. And how do you treat it? You treat it by avoiding fasting. You have frequent meals with carbohydrates. You restrict your fat contents, so you will have minimal long-chain fatty acids, and you just make sure you have enough carbohydrates. And if you do this, this will improve your exercise intolerance. So this is a very good slide. So the paper that I asked Johannes to send out for the metabolic myopathies from muscle and nerve, this is actually adapted from that paper. It's a very short paper to read. But basically, this tells you the difference between the glycogen storage disorders and the fatty acid oxidation disorders. And again, keep in mind, the CK can be frequently normal, except for CPT2 and McArdle's. You can have normal EMGs for both, right? But again, and you can have exercise-induced weakness, right? Or eventually fixed weakness. If you don't treat a mitochondrial myopathy at the end, after sometimes decades, they will have fixed weakness. But again, what are differentiating features between them? So if they have a second wind phenomenon, that's McArdle's. That can't be a fatty acid oxidation disorders. In fatty acid oxidation disorders, frequently they'll get rhabdo if they fast, or if they're ill, or if they have high fat content, right? And then obviously also the exercise intolerance. If it's very high intensity exercise, you'll get a glycogen storage disorder manifestation. If it's low intensity but very long duration exercise, that's where you get pain and stiffness. Okay, that's more of the fatty acid oxidation disorder. And obviously the biopsies are very different. You know, one of them is glycogen stores, one is lipid droplets. Okay, so again, you know, if you see this, you're thinking fatty acid oxidation disorder because these are lipid stores. If you see this, this is, you know, stores of, you know, glycogen over here. And if you see this, this is ragged red fibers, this is mitochondrial disease. And then also from that same paper, they talk about how to work it up. So if you have somebody who's got exercise intolerance and or rhabdo, especially if it's recurrent, you know, and you examine them and there's variable proximal weakness, there's CK, elevation EMG abnormalities, you know, could it be glycogen storage? Could it be fatty acid oxidation? Is it high intensity exercise or is it low intensity, long duration exercise? If it's high intensity exercise, think GSD. If it's low intensity, long duration exercise, or after cold or fasting, think fatty acid oxidation. You want to do the appropriate molecular testing, genetic testing. Now remember, if it's positive, you have your answer. If it's negative, it could be negative, or it could be just you don't have the gene in the panel, so you have to pick a different panel. If it's a variant of uncertain significance, then it could be a GSD, it could be a fatty acid oxidation disorder, and then you're stuck doing things like a muscle biopsy with enzyme testing. But it's going to be tricky to show. And if it's a fatty acid oxidation disorder, you may get abnormal levels of carnitine and acylcarnitine, frequently lower. Okay. So the last thing to end with is the differential diagnosis. Not everybody with exercise intolerance has a metabolic myopathy. You can see this with certain muscular dystrophies, even without much weakness. So especially with some of the limb-girdle muscular dystrophies, especially 2A and 2B, they sometimes will have exercise intolerance, if you remember from my lecture 2 days ago, with very low weakness. So not every episodic exercise intolerance or episodic weakness is a metabolic myopathy. That's the first thing you want to think about, but it's not always the last thing. It could be a muscular dystrophy, for example, right? You know, could even be something like myasthenia gravis, theoretically, right? Obviously, you want to do tests to rule those out. So again, you always need the exam and the history. You need to know the right tests, which ones to do. There may be a role for muscle biopsy for metabolic myopathies, but in this case, almost always genetic testing first. I'll stop there. Any questions on metabolic myopathies? Mitochondrial, glycogen storage, fatty acid oxidation. Again, a challenging diagnosis to make. And if you're not sure, just refer them to a neuromuscular specialist. There's no shame in that. So again, for those of us who haven't read the article that Johannes sent around, it's a quick article. You could just skim it. Okay, it takes about 10 minutes to read, maybe even less, and that's all you're going to need for your for the boards.
Oh, shall we try to develop for Esther Pickens? They have not showed up for a pacemaker yet. Yeah. Okay. So page E, follow again.
Wait, I'm sorry. Can you speak up because it's my speaker's far away.
But Mao is just I don't think he knows his speaker's on.
Oh.
Yeah.
Got it. Okay, easy enough.
Hello.
Yes.
Yeah. So yeah. Can you repeat the question? Like it was
No question.
no question. Okay.
You're good.
Okay.
Okay, perfect. Okay, so I think with that, we end our week of muscle disease. So hopefully people got something out of it and keep in mind. And remember, as long as you have an organizational framework, you won't have to memorize everything, you know, for the limb girdles, for the metabolic myopathies, for the myosidides. Okay, so we'll stop there. Thank you, everybody, for waiting. Okay, and everybody enjoy the day.
Thank you.
Thank you, Dr. Anziska.